pleasure for me to have Dr. Palmberg here. I met Dr. Palmberg a long time ago, and I lived for 2 months in his house, and was a great experience because I learned a lot with him. Okay, thank you.
Thank you.
Okay.
Yeah.
I'm going to take your chair. Is that okay?
Take my chair?
You need your chair?
I was going to sit in it to run the computer.
Oh, okay. Sorry.
Yeah.
Then I'll get my chair back.
At any rate, I'm very proud of this guy because he's probably the last, what we say in English, polymath in ophthalmology. There's nobody else who's done every fellowship or has been involved in everything that's done. And I think probably you have one of the outstanding residencies in ophthalmology in all of Latin America and really in the world. And you know, the Laser Cataract Center for the FDA trial, the Center for the In-Focus Microshunt we're going to talk about. You can do things in your practice in glaucoma I can't do in mine yet. Ignore this. I showed this in Kuwait the other day, and obviously you're not in Kuwait. By the way, being in Kuwait is kind of interesting. You're at the bullseye of the Middle East. Iran, Iraq, and Saudi Arabia surround this little country. And who do you use this in? Well, children, when angle surgery has failed, Barbell implants are by far our best option right now. And they do give lower pressures than the Ahmed. They have a larger surface area. And so in kids we use it. People with poor prognosis for bleb surgery because they've got scarred conjunctiva. They had a buckle done by somebody when people did buckles. Or when they had extracapsular surgery and people actually went through the sclera instead of clear cornea. So some of these problems, fortunately, these very difficult situations, we're not creating as often as we used to. It's much easier otherwise. But if there's scarred conjunctiva, previous failed trabeculectomy, for example, great case for putting in one of these implants. So poor prognosis, children where angle surgery failed, ICE syndrome, epithelial downgrowth, active rubeosis, uveitis, good places. And here's rubeosis, you know what this looks like. So the device is available, the Ahmed, which of course has a valve, so it's open right away, and the Barbell and the Adi, which have a large plate but no flow restrictions. So you need to form a capsule on the outside, and you need to tie it off for the first 3 to 6 weeks, and then it can be opened up when you have enough capsule that you wouldn't have hypotony. There was a trial comparing the Ahmed to the Barbell, and the success rate, or the failure rate of the Ahmed was higher, the pressures were higher, the meds that were needed were higher, the complications were a little more in the Barbell, but this included people with neovascular glaucoma who lost vision from retinal problems. And really, I don't see serious complications with the Barbell, but I do see this better success rate, pressure, less need for medication. The AeroLab, it says, is being tested. No, it's already been tested. It's been approved by the European Union. And at a year, there was 93% success. The average pressure was 13.6 on an average of 1 med, just like the original Barbell study done by Barbell, in which he found average pressures, the success rate very similar, and an average pressure and the need for medicines very similar to what we're getting from the ADI. Now you're saying, why is it ADI, A-A-D-I? Well, they asked me what to call it, and they're making it in India, and I thought, well, how about the AeroLab aqueous drainage device? So I thought, well, I better look up what these initials mean on Google. And it was adult attention deficit disorder. So, well, maybe not. Okay. How about AeroLab aqueous drainage implant? So I did ADI. It turns out it's a word in their language. It's a boy's name, and it means hope, new beginning. Whoa. And it's also the name of the 4th month in the Tamil language of Southeast India, where AeroLab is located. It's their 4th month. It's the month in which you buy expensive things with a big discount. It's the end of the year. So hope, new beginning, and big discount. And so I gave this back to them, said, we could call it an oddity. Palmberg, you're a genius. I said, no, I Googled it. I don't know Tamil, to come up with the name, but that's where the name came from and what it means to them. So we know with barbell compared to a trabeculectomy that until you open the tube, which takes as much as 6 weeks, the pressures are going to be higher. So you need to keep the pressure down with some fenestration in the tube, medical therapy in the meantime. But that when you go on out to 5 years, in people who'd had a previous cataract or had had a previous failed glaucoma operation, a trabeculectomy, the barbell won compared to a mitomycin trab. Now, it wasn't a fair comparison. It was in people who'd already had surgery in their eye, and there is now a primary tube versus trab trial where it's the first glaucoma surgery, and the trab is actually ahead than the tubes. But particularly for people whose pressures were 18, 19, 20, you can get lower pressures with the trab than you can with the tube. In anybody whose pressure is higher than 21, it's actually equal in primary surgery for the success. And no matter how you looked at the success in the tube versus trab trial, the success rate or lack of failure was higher with the barbell than a trab with mitomycin. Well, what kind of problems do you get into with these devices? In the tube versus trab trial in the United States, you had corneal problems, particularly if the tube ever touched the corneal endothelium. So it's very important to put the tube in such a way that it's well off the corneal endothelium, that the tube entry, which you put through a needle track, does not go through the peripheral cornea. It goes through the scleral spur or the trabecular meshwork. Now it happens that corneal endothelial cells do not move over a trabecular meshwork. The Schwabe's line cells at Schwabe's line make a barrier that corneal endothelial cells don't grow over. But if you have something touching the endothelium, even by a needle track going through the endothelium, and it's constantly the tube moving a little bit with blinking and rubbing the eye perhaps, you could have corneal problems, as you know happened with the CyPass. Now the CyPass device, which was pulled off the market because it sometimes touched the corneal endothelium, was actually pretty, and in trabs you've had problems with leaking, with dysesthesia, and with hypotony, and those problems seem to be pretty much eliminated with the in-focus microshunt that we'll also be having in surgery tomorrow, and that Juan has probably already talked to you about quite a bit. So another problem with the tube versus trab trial were tube erosions. And in the study in the United States, 5 out of the 107 patients, about 5% then, had a tube erode by 5 years with the barbell. Now, Felix Hill in Mexico City, one of my heroes, doesn't have an eye bank, could not afford to go out and get patch graft materials to put these tubes in. When they were put in near the limbus, and they have the rubbing of the upper eyelid, it could thin out the conjunctiva, eventually expose the tube. So what he came up with was a 3-millimeter tunnel in the sclera with a needle track. And when you do that, the tube emerges from the eye behind where the upper lid rubs. So you not only want to be 3 millimeters from the limbus, but you want to be between 11 and 1, not off to the side because the lid might be able to rub in that position. And that was 1% tube exposure in his hands at 5 years, and he did 9,300 AMEDs and then analyzed a sample of 10%, and that's where he came up with a life table of only 1%. So that finding of Felix Hill, that you don't get tube exposures when you emerge a tube from the eye, was transferred also to the in-focus microshunt and to the Zen, the Aquis Zen, now owned by Allergan. And when I was advising both of those companies, I said, don't put the device straight nasal, because the Zen people wanted to put it straight nasal. They're going to do it at cataract surgery. It's across the anterior chamber, putting a needle out. And I said, don't do that. You're going to get an exposed tube. And they said, oh, no, the cataract surgeons are going to prefer that. Well, they did it. They got an exposed tube. They got an endophthalmitis. They said, what were you telling me about Felix Hill's idea? Yes. Okay. So sometimes companies listen, sometimes they listen when they have to. Anyway, so usually you're going to put a bar belt supratemporal or infranasal. You're not going to put them infranasal or supratemporal. Why? Because you can interfere with the oblique if you put it up there. And somebody reported 67% motility problems and said no one should use the bar belt. And some of us said they should not use the bar belt. Or at least they shouldn't put it in that location. Now, I teach residents, and they start doing surgery in their second year. And imagine somebody's going to shove a needle, 23 gauge sharp needle, into an eye that's phakic. Okay, and I'm going to sit there and watch them do this. How am I going to be completely relaxed about this? I had to come up with a technique where you cannot hit the lens. It's not possible, okay? I will show it to you. It made me more relaxed when I came up with it. Well, first thing, we're going to open up the conjunctiva and notice something. Notice where we're going to go. We've opened up the conjunctiva. We started with a lateral relaxing incision, got underneath the conjunctiva and tenons, everted them so we could see what we were doing, saw bare sclera, and the insertion of tenons about 1 millimeter behind. We passed our scissors with the blades closed underneath tenon's capsule because we averted the conjunctiva and tenons. We could see bare sclera. We could get under, lift, and come across. And then we could put one blade back in and cut right at the limbus. So we're able to see exactly what we're doing, and we're getting in the space under tenon's capsule. All of these things either belong above or below tenon's capsule. This belongs below tenon's capsule, not in the middle of tenon's capsule. You will notice that there is no bleeding into the tissue if you open the conjunctiva this way, because you're only cutting vessels at the very limbus in conjunctiva or in tenons, and your scissors have lifted above the vessels on the sclera when you're coming over, and you didn't rub them. And as I tell my residents, if you don't cut it, it won't bleed. It's pretty simple. And now you want to know, where can I poke through safely with my scissors to get through the intermuscular septum supratemporally? How can I know where I am? Because sometimes when you block an eye, it'll tort because of the oblique as much as 20 or 30 degrees. So how can you know exactly what you're doing? What are you looking for?
The muscle you need to.
How do you know where you're not going to hit the muscle when you go through with your
Well,
scissors?
you need to separate.
Well, first of all, after you've opened the conjunctiva like this, you look for the vessels that are coming off the muscles. They're coming in laterally from the lateral rectus. They're coming down from the superior rectus, usually in two groups down from the superior rectus. If you see the vertical vessels on the surface of the sclera here and here, you can go there, and you will never hit a muscle. There is no muscle there. Now remember, the muscles could be as wide as the cornea. They can be as tall as the cornea, but they will never be both. So that if you identify the vertical muscle, the vessels coming in vertically and horizontally, and go between them to shove, you can do it with impunity. You will not hit a muscle. And then I want to take two muscle hooks. I don't use traction stitches in the cornea. I don't like them. You have an epithelial defect to begin with that. And you're tugging down on the eye and the levator aponeurosis all the time, and that's not necessary. You want to hold the muscle belly up. You want to clean any check ligaments. So you put two muscle hooks under the superior rectus and run one back. You go under the lateral rectus, put the second one under, and run one back. Now one of them is holding the insertion of the muscle so you have counter traction, and the other one goes. That's cleaning the check ligaments. Now you're going to put two muscle hooks under, say, the lateral or superior rectus, either one. You're going to separate them. So I call this reverse chopsticks. I lived in Japan for 2 years. So if you hold them like that, and this one is hooking the superior rectus, and this one is lifting the muscle away from the globe, you can now slide the barbelled implant, which is wide, you're going to put one of those arms, the sides, underneath it. You can slide it underneath. So here's the video of sliding it underneath. We've got the two muscle hooks. We're separating them, lifting the one behind, and now with your other hand, you can slide the device in. And then you're going to do the same thing on the other side. And after you've got it in place, you're going to make sure that as you fixate the globe, as you fixate one of the muscles, that you can slide this device left and right, in and out, with absolutely no resistance. It has to lie on the sclera. If it's sticking up a little, it's stuck in a check ligament. Go find it, get it free from the check ligament. It has to lie right on the surface and has to move freely, so it's not trapped by anything. That's the thing that can cause muscle motility problems that are avoidable. And then slide it back 2 millimeters. Slide it back 2 millimeters so the muscle is not going up and over, which would change the action of the muscle a little bit, but it's going straight back because it's a couple of millimeters back. So then we go on to the next step, which is the bicycle kick. In case you don't know what a bicycle kick is,
chilena.
here's Rinaldo doing a bicycle kick.
That's a chilena. Chilena.
Chilena? Is
Yeah.
the name for it?
Yeah. Right? That guy's una chilena.
So there he kicks it over his head. Okay, so what's my bicycle kick? My bicycle kick is how to put the suture in the sclera to anchor the device exactly where you want it. So how do you do that? Well, one of the things you do is use the muscle hook. You hook the muscle, pull it nasally. So this muscle hook is doing 3 things. I love having instruments do more than one thing. This muscle hook is pulling the globe in, okay, letting me see the insertion, pulling the globe in, letting me see the edge, and I want to be 2 millimeters behind it and just next to it. And I'm twisting the muscle hook so it's holding the conjunctiva out of the way. So now with the other hand you can pass the needle. Now the sclera up near the limbus, as you know, is like at least a ½ millimeter thick. And the sclera back here behind the muscle insertions is thin. And sometimes it's even staphylomatous. So you do not want to take a deep bite here. You want to take a bite into the sclera, but you want to be able to see the needle at all times as it's passing, you know, diffusely, but under the surface. You've got to be able to see it. If you go too deep, you can get through something called the retina. And if you happen to do that, you have to get cryo and cryo around that spot so that the retina will stick there. Or otherwise, you'll have to call it Dr. Barukal in my place to do a pneumato-retinopexy to get the retina back up. Anyway, so don't do that. So here we go. Here's the pass. That's the second-year resident doing this. I am playing the muscle hook, but they're doing the rest of it. So that's a good depth. It's all you would ever want to go in depth.
And what suture is that?
This is probably an 8/0 nylon, or it could be a proline, something a little more permanent. The device will get stuck in position, and then you can hook through the device with the needle and pull it in a little bit and tie it. Now we have to ligate it with 7/0 vicryl. Usually go around twice, and now we usually do the fenestration of the tube later. You want to know that it's ligated. It has to be ligated. So we're going to ligate it and try to put some fluid through. So one thing that helps to know about that is to take 2 tying forceps while there's fluid in this tube that we're ligating. We've tied the knot. We want to know if that knot's secure, tight enough that no fluid can go by. So you take 2 forceps, pinch with one, and with the other you pinch and pull, and you milk the tube. Get some of the fluid out. So now there's air. And then when you put a 30 cannula in the tip and try to squirt fluid in, you'll see the air move down and come back, move down and come back, and you know for sure that you have it ligated. And it has to be ligated, otherwise you could have severe hypotony.
So in your ligation, you just ligate the tube, or do you put the ripcord through and then ligate around?
I have not used ripcords.
Okay.
The people in London use ripcords. I have not done that. I've just let the stitch either melt or I have lasered it. Some people put something inside of it they can pull out. It does involve a stitch coming up to the surface. I'm a little worried about possible infection with that or difficulty getting it out, but they're happy with it. I'm happy with what I'm doing. Probably either one is fine. So the next thing is, how do you avoid sticking that needle into the lens? So here's what I came up with. First, we bend the needle that's going to go into the eye. Now, many people bend the needle back. In which case, as you come forward with your hand, you will not be able to see the needle. That didn't make sense to me. So I bent it sideways, like this, and a little bit up. And you can actually think of a needle as a malleable instrument. You can bend it any way you want to. Fluid will still go through it, interestingly enough, with a needle. But I bend it sideways about 3.5 millimeters from the end. And I lay it down and I say, okay, if I enter the sclera here, that tip can, and I angle obliquely into the supranasal angle, there is no way this needle can ever hit the lens. Well, how do I know that I'm going to enter there? I make a groove. A little groove about 1/3 thickness, which also gives you something handy to hold on to with your forceps while you're putting the needle in. So here, this is a second-year resident doing her second case. You can see the tube is already ligated there. And here we go. So we lay the needle down to see where to make the groove. You bend the needle first about 3.5 millimeters. You make the groove. Hold on to the groove. 0.2 or 0.3 forceps. And now you start angling to the supranasal angle at about 1/3 depth. As you advance, you start pulling the globe back towards you. And the reason for that, I'm telling her, you see this, that forcep is me teaching. Well, what was an advantage of this is if you have somebody whose nerve is really badly damaged, the pressure is quite high. You want it down now, and you want it down forever. This combo operation has an advantage that the trab works for a while, and if it fails, and the cases I picked were cases where there had already been conjunctival surgery for some reason, or a corneal transplant or something else, it happens now that that guy's pressure is 11, and he's somebody who really needed it. His mother had gone blind at 13, and he has been stable for 20 years with pressures that have been in the 6 and 9 in the two eyes. So if you get the pressure low enough, you can stop glaucoma from getting worse in just about all cases. If you get vitreous in the tube, your lens, there's only one thing to do. Call Juan, yeah, or somebody else. You just, unless the vitreous strand has come around, it's under a lot of tension coming up to the tube, and you can yag it and it pops back, you're going to have it sucked back. And you don't want to just do a vitrectomy in the anterior chamber. It needs to be pulled back through the sonnular diaphragm with a vitrectomy. Now, what are you going to do? Here's the patient, neovascular, had a barbell, it got engulfed, pressure's too high. Here's another tube that's been put in down below, infranasally, and the pressure's back up to 50. And the tube is just socked in, the iris has just socked up around the tube. Even though it was above it to begin with, it's now encased. What are you going to do? What are you going to do?
Come on, guys.
What would you do? Pull it out, stick. Huh? What would you do?
Can you laser to the around like a Yale?
Yes! But off a gonioprism. So you look inside the eye with the gonioprism, And here's this tube stuck in like that. And you see that here's the tip pushing the iris down. And all you have to do is use an argon laser and make an iridotomy inside out with about 1.5 watts, 1/10 of a second. And you see, once the tip of the tube was free, whoosh, pressure was down to about 11. It stayed there. God is merciful. So, those are some things to say about the technique on that. I do want to share one other thing with you about what we have learned about this target pressure. You ever heard of the term target pressure? Okay, I made it up years ago. And I've changed my mind about how it should be thought of. And I just want to share a little information you may not have seen about it. Where do you get paradigm shifts in the managing of things? Well, one place is like this. This is a functional electric typewriter that I wrote things in high school on in 1958. It still works. Nobody uses them. Why? Because we got computers. Have you ever even seen a typewriter?
Yes.
In a museum?
No.
No. Okay. So there's one paradigm shift. Here's another one. When I'm telling residents, when you're working on the nucleus and you dial it around in the bag like a telephone, and they say, "What?" A lot of analogies have died. So that was obviously a totally disruptive technology. And obviously when you got antibiotics, that was in treating infection, that was big. You get all kinds of new drugs, internet communication, digital imaging. Just think what OCT has done to ophthalmology even in your lifetime. Now with diabetes, for example, they have found now, this is probably going to get very practical soon. They have a device you can stick in the skin and measure the blood sugar level for an insulin-dependent diabetic. And then they have insulin pumps. The problem was, how do you have the high-powered computer necessary to take the sugar information with an algorithm as the sugar is rising to say, how much insulin do I need to give to prevent a big spike and just have it come to the right level and not too low? And you know where that high-powered computer is? In your pocket. It's done with iPhones, with smart computers. And now there are people running around with hemoglobin A1Cs of 6.5 who used to run 8. And if they're down there, the amount of proliferative retinopathy that you're going to see is going to plummet. For every point lower of hemoglobin A1C you go, you reduce the risk of diabetic complications by 42%, I think it was, in the Diabetes Control and Complications trial, which I was involved in. It was based on my natural history study in St. Louis. Hepatitis C, there's no cure. It costs a lot of money, but there is a cure. Not just taking antivirals for a long period of time. You just take this new one for about, I think it's 12 weeks or something, and you're cured. 97% of the people are cured. So that changed things. But there are things like prostate cancer, but because all the treatments are pretty bad, and the disease isn't always fatal, that they don't know what to do. They don't know whether they should watch you or what to do. So, but if a good treatment came along that was safe, it would change everything. That's like glaucoma. That you had an effective treatment, and it had a lot of side effects. So you didn't want to use it too early, like trabeculectomy. But if you could do it in a very safe way, it would move way forward in your treatment choices. So, oh, by the way, I should mention, this guy died.
Oh, yeah.
This week. Now, do you see any resemblance? Read my lips, no new Texans. Actually, what happened is, I was going to say, no nude Texans. Came out, no new taxes. People cheered. Wasn't going to tell them it was a mistake. Not going to do it. Wouldn't be prudent. So anyway, a producer from Paramount Pictures came to Bascom Palmer several years ago when he was president and said, you have a doctor at Bascom Palmer, and we understand he looks like Bush. And 176 people had told me at the time that I really, that's not him, that's me. No, that's him, not me. That's me. Anyway, at that time I really looked like him. So 176 people had come up to me and said, anybody tell you look like President Bush? So I came into the development office 20 minutes after the producer had been sent away telling him, we don't know who you're talking about. I could have had a bit part in the movie. I saw the movie. I could have done it better than the guy. But anyway, great mile in. Anyway, great guy. What's the chance your patient's going to get worse at different pressures? Sometimes hard to know. One thing that'll help, though, is to put drops in correctly, and one way is not like drinking. You don't want to put drops like that. Turn the bottle upside down. They don't run out. Upside down. Use your little finger. Squeeze. And you can teach patients to do that, and they'll be much more effective than if they do this. Turn the bottle upside down. Use your little finger to hold the lid down, making a little place to receive the fluid, and then squeeze. And if their eye feels wet, they got it. But the question is, what's the chance of a person getting worse who's got early glaucoma at different pressures? Now, I came up with the idea of target pressures of people with advanced damage needing low pressures because when I did my fellowship in St. Louis with Dr. Becker and Dr. Cass, the idea at that time was get them in the normal range. If they're around 18, 19, they should be fine. And he had a lot of advanced patients. And I thought, how can I get, for those of you who are in glaucoma fellowships, how can I get a really good idea about the disease in a chronic, slowly progressive disease in 1 year? You have to learn from the past. You're not going to learn it from 1 year's experience. You got to learn a lot. So after church on Sundays, I would go in and look at the charts that had 10 and 20 years of very good visual fields and see what happened to people. And Dr. Becker would be writing, done stable, doing well when the pressure was 18, even though if you look back 10 years, they now lost half of their remaining visual field. And if they were around 13, not so often. No more than 8% had gotten worse if their pressures were in the low teens. And Dr. Becker, unfortunately, was the kind of person that you couldn't very well go to him and say, I think you're wrong. and I was just too chicken. I think one of the things I learned from Dr. Becker, and you should learn from your teachers what not to do, is don't be so unapproachable that they can't talk to you about their ideas. You frequently will learn from your fellows. I came up with something called a compression stitch over a bleb if it's leaking on the side. You take a bite in the cornea and come out behind. And I showed this to one of my fellows, and I had taken a bite of the sclera, gone through, under the bleb, come up over the top. And I had thought of him as kind of a reclamation project. He came from a weak residency surgically, but a very bright guy. And he looked at what I showed him. I said, look at this. I walled off a leak, and it healed it. And he says, oh, why didn't you take a banter stitch here and take a bite in the cornea and take a bite behind over the top? That's much better than my idea. So actually what I do is what he told, the reclamation project told me. So listen to the people that you're training because their minds are not in concrete yet. You got a chance. Well, anyway, I found out after I came to this concept that Paul Chandler had the same idea 17 years before me and had mentioned it at, that part, had said it all and published it in the AJO in 1960. If a nerve is badly damaged at both, in other words, at both poles, you better be under 15 or they're not likely going to be stable. Now, this is his clinical experience, and most of his own fellows didn't believe him. And the full thickness procedures they were doing in those days to try to get those pressures gave flat chambers, all kinds of other problems. And people like Dick Brubaker said, no, that guy was crazy. I mean, he eventually came around, but most people said, if the nerve is getting worse at 18, it's nerve rot. It's not anything to do with the pressure. How can a pressure of 18 be harmful to somebody? It's the normal range. Diabetic, high blood pressure, you wouldn't feel that you needed to be low blood pressure or low blood sugar to stop the problem. But glaucoma is different. Glaucoma is different because there are reasons why a pressure of 18 could be harmful to a very sensitive nerve, and a pressure down closer to 10 or 12 might be less of a problem. So it's different. He also said if you have less damage, one pole of the nerve, well, maybe you'd be all right around 17. And if the nerve is not damaged, it's ocular hypertension, you could probably just watch it up to a pressure of 30. So he got most of it right. 30, 40 years before the rest of us, but people didn't believe him. Now, if you did a receiver operating characteristic curve on a population in the United Kingdom, you would say that only 1/3 of glaucoma damage is due to the pressure distribution of glaucoma patients being different from the pressure distribution of normals. Only 1/3. In Japan, where the average pressure of glaucoma patient is 15.6 and the population is 15.0, 92% of their glaucoma is normal pressure glaucoma in the normal range for their population. And yet, if you lower the pressure down to around 10 with a mitomycin trap, you have about 4% of the people getting worse in the next decade, and if you don't, it's 92% get a lot worse. How can that be? Pressure's not the problem, but abnormal sensitivity to the pressure is, and it can be alleviated by having the pressure even lower. So how much of glaucoma damage is pressure dependent and avoidable? The answer turns out to be just about all, even in normal tension glaucoma or high tension, and that was a big surprise. And what we should have noticed, despite the big overlap between glaucoma patients and the general population, is that there was only one person in the bottom half of the distribution who had glaucoma. So perhaps low pressures can protect you against other things that are wrong in glaucoma: faulty autoregulation of blood flow, poor flow, pressure gradient across the optic nerve, pinching the nerve, whatever it is, getting lower seems to reduce the risk. And if you go back to the Baltimore Eye Study, you see the prevalence of glaucoma versus pressure approaches 0 when you get down around 11, 12, 13. So what could it be? Well, it could be that we're improving blood flow or reducing strain on the optic nerve. And in fact, that turns out to be true. Whatever the mechanism is, and we don't know, we can compensate for it. We have the data. Now, one way I do it was valve-like trabeculectomy to try to do what the in-focus microshunt does. I wanted a pressure gradient between the anterior chamber and the sclera that was about 5. Because I knew my nylon stitches are going to melt someday, and since I used mitomycin, and when they melted after 4 or 5 years, which nylon does, you did not want to have severe hypotony. And so I would carefully check the pressure in the eye, and I'm showing you this because tomorrow, when you put an in-focus in, you want to check that the pressure in the eye at equilibrium flow is no more than 5 or 6 millimeters of mercury. If it is, somehow that tube might be crimped or pinched. And just that simple maneuver would solve the problem. And then I would put my stitches in and adjust till the pressure was about 8 to 12. And doing that, I had an average pressure of 11 over the next several years. And people with a pressure of 26 with a lot of damage, 14 decibels, here are their fields over time, their pressure over time. Here's their mean deviation, their pattern deviation over time. And there was no net change in this whole group of people. Now, nobody believed this until the HES study came out that I was on the monitoring committee and showed the same thing. That if the pressure was down around 12 or 13, even in very advanced cases, you had almost nobody getting worse. Very, very few. There were cases that looked like they were getting better and looked like they were getting worse. They were equal and opposite. I thought that was noise. But Kyoko Ishida, my fellow from Japan, who was the smartest fellow I ever had, showed me that the maximum pressure correlated with getting worse. So it was, some of it's real, some of it might be repeated testing. You're going to get a positive or a false positive or false negative. But, oh, and by the way, if you wonder whether the maximum pressure or the average is most important, it totally depends on the design of the study. If you do an interventional study like a TRAB and some of them can fail, it will look like peaks are important. If you do a study like EMGT where they put everybody on the same medicine and followed them, it won't look like the peaks make any difference. It'll look entirely attributable to the mean pressure because they're at the same pressure over a long period of time. So don't worry about that. If your house is on fire acutely or chronically, it's not good. Now, we did find in that study, in these advanced patients, that not a single one whose pressure was 13 or less the whole time got worse out to 10 years. We did find that if they ever got to 14 to 20, that 21% were worse. And in the 6 patients who ever got to 21 or more, and even though we intervened right away, 38% had gotten worse by 3 decibels on 2 consecutive fields compared to the baseline. So the maximum does matter. But here was what was fun. The people who always had that low pressure had gotten better by an average of 2 decibels. They had gotten back 15% of their visual field. Another one of my daughters. Hi, Raquel. So, and the people who were in that middle group had gotten better by an average of 1 decibel, and the other people were stable for a while in the mid to upper teens, but gradually got worse. So, this is a surprise. You can get back some visual field. Some of the cells are not dead yet, and they can be resurrected to function. They're just stunned or in a coma if you get the pressure low enough. And not everybody needs a pressure down around 12 who's got advanced damage, but your chances of getting worse are much, and there are about as many people better as worse at this point, measured. The higher the pressure, the higher risk. So I want to stop talking about a target pressure and start thinking of a dose-response curve. The percentage chance you will get worse at this pressure, that pressure, the next pressure, the next pressure. And for advanced patients, it looks like this. If you came down from 26, you've got at least a 70% chance of getting worse if your pressure is still 20. If you are in the mid-teens, which people think is a great result for a TRAB in an advanced patient, it gets 15, you still have a 30% chance you're getting worse. If you're down around 12, then you have a much reduced, almost, you have as many people getting better as worse. Some of it's real, some of it's noise. It's hard to separate them when they're the same. But what about mild cases of glaucoma? In the CIGIT study that I was also on the monitoring committee for, and this is where you might get some new information, there was no net progression in either the people randomized to medicine or surgery. They both have about 5 decibel loss at diagnosis, early cases. And I thought, well, how can you do better than breaking even? You know, but I noticed something. There were about 20% of people in the study who looked like they got worse on 2 consecutive fields. And I said to David Musk, who was our guy running it at the time, well, how can that be? How can the people get worse and the mean isn't changing? The answer had to be some people looked better. And I thought, oh, well, maybe it's noise. It's about equal numbers. Well, it turns out, because of Kyoko Ishida's insight into my data, only because of her insight, not mine, my fellows, that we realized that we needed to reanalyze what to do with the mild early patient where we used to think 17 was optimal. And when we looked at it, these people randomized to medicine versus surgery, how could we tell if they're equal numbers getting better or worse? How could we tell how much of it's real and how much of it's noise? How could we tell? Well, one way we could look and see if it correlates with anything, and it does. It correlates with the intraocular pressure. Well, if it correlates with the intraocular pressure, that sounds like glaucoma. It also correlated with gender. Women are 60% more likely to have a recovery of 3 decibels of their visual field when you lower the pressure than men. If you have cardiovascular disease, you've ever had a heart attack or stroke in the past, we can stabilize you, but it's much less likely you're going to improve on your visual field. So those things don't sound like noise. Well, here's the percent chance that you'll get back 3 decibels at a peak pressure during the first 10 visits over the first 5 years, that you will get the percent of visits that were better. And now, let's subtract the people who looked worse. What's the noise level in Humphrey visual fields? 5%. So what if you took 5% away from both of these numbers? Or you just subtracted and then you got the difference. That has to be real. At least 12% of these people got back 3 decibels of their visual field. And I've had patients where I operated on them and got their pressure down. They said, you know, I see clearer. And it sometimes takes 6 months, a year, 2 years for it to happen, but it does happen. And the average, if you can get down around 13, do you happen to know any operation that can get people down reliably to around 13?
I do.
Okay. Compared to a trabeculectomy, which in some people's hands can get 11, 12, 13. In other people's hands gets you 15 because they're afraid to cut one more stitch because they're afraid of hypotony. They don't have a precise way of adjusting the pressure gradient across the sclera. Do you know any operation that has a precise gradient across? Jeez, imagine that. So, and then the next group up, it's somewhat less. And then the next group up, it's a break even. And that's the people who had those pressures around 17 where we said, you know, they were breaking even. There really were people getting worse. There really were people getting better. How about if I take you to an operation where you don't have any more getting worse than noise of the test, within 1% of it, of noise, and you actually do have a net of 12% of people who are genuinely better. Whoa. This is mild early glaucoma. Now, with the in-focus microshunt, it's going to first replace, for people who can afford the device, until it's eventually maybe made in India for $1 and 30 cents worth of mitomycin in that situation. In the meantime, it's going to cost money. I don't know how much. I turned down the stock options because I was giving talks for them. I understand I blew about $300,000, but that's, I've got my ethics. At any rate. But it looks like you might be able to do that. Now, what about the in-focus microshunt? Microtubes, short version, yes. Okay. So where did this thing come from in the first place? Francisco Fontes. So Francisco Fontes from Venezuela, who came up to Bascom Palmer and didn't understand that you cannot get a residency at Bascom Palmer if you are from Venezuela. But he happened to do an internship over at Jackson Hospital where his attending was the husband of a member of our admissions committee who said, this is the most intelligent, incredibly good doctor, you ought to seriously consider him, and he got into the residency, even though it was impossible. 700 applicants for 7 spots, you know. At any rate, unfortunately he died of cancer, but before he did, he came up with the idea, how about a microtube to substitute for the scleral flap of a trabeculectomy? And he got together with Len Pinchek, who had invented SIBS, a polystyrene that has been used in 1 million cardiac stents with 10 years of follow-up. And it is really, really biocompatible. It has no reactive groups on the surface. I have seen them take this device and throw it into 10 normal nitric acid and nothing happened to it. Now, on the other hand, don't put any petroleum ointment on it. You could dissolve it. So no ointments, but it's never going to dissolve in people. You've had them in people up to 9 years. It's not going anywhere. Now, the Zen in-focus microshunt, which is made of cross-linked collagen, will probably eventually dissolve. And so particularly if you're going to do this in a younger person, you may want a device that's going to have a longer survival time. Now, they got together with Jean-Marie Perel, who is the guy who invented the vitrectomy machines that made it work. The light pipe and the vitreous infusion suction cutter. People had vitrectomy machines before. They would grab the vitreous, pull on it, and pull off the retina. But until somebody would just nibble at it and had a light pipe to see what they were doing, it wasn't practical. So the same guy, Jean-Marie Perel, still going, 45 years later, And so he came up with, let's think about the dimensions of the device to give us a pressure gradient of about 6 millimeters of mercury. And you can do that using the Hagen-Poiseuille law. Well, I don't know. Jean-Marie said Poiseuille.
What is that?
Poiseuille. So, I mean, he's French, so, French Swiss. I'm, as best I can do it, is saying it. So, at any rate, any plumber can tell you this. If you know the length of a pipe, you know the internal diameter, you know the rate of flow through it and the viscosity of what's going through it, you can calculate the pressure drop from one end to the other. And they need to do that to design your house, you know, decide how big the pipes need to be so that you actually get water coming at a reasonable rate into your house. Now, whereas the trabecular meshwork resistance in your eye can vary incredibly between people who have a pressure of 10 and episcleral venous pressure of 8, very little resistance added, to people who have a pressure of even 20. They have 10 times as much resistance in the trabecular meshwork, and they're all normal. And then you have people with glaucoma, the pressure is 30 or 40, they got 30 or 40 times as much resistance. But you all, if you have never had very bad uveitis or cyclodestructive procedures, you are all making 2 to 2.5 microliters per minute of aqueous. It's a very narrow range in the normal population. It does go down to about 1.5 at night, but it's 2 to 2.5 in just about everybody where it's measured. So if you have a flow rate that's almost the same in everybody, you can calculate the pipe diameter to give a pressure gradient in a very narrow range in people. As long as their trabecular meshwork is bad, the pressure is high, and you're bypassing it. So this device, put through a needle track, and there is one of them, has this little fin on it that will hold it in place in a little pocket you make. And it is designed to give a pressure gradient of 6. Now, to tell you the truth, if you calculate it, it comes out about 3.5 or 4. But it's hydrophobic. Hydrophobic material has some properties that make it act like it has a smaller diameter because of the reaction of water with a hydrophobic material. It doesn't wet. So that you actually, when it's put into an eye and perfused at that rate, you get a pressure of 6. You also have to prime it because it's hydrophobic. You have to prime it, just as you do with an AMED, let's say. So it's also made of a non-reactive polystyrene. Here it is. Here's the structure. Look, there's nothing on there. No amide, no hydroxyl, no carboxyl, no nitrogen, none of the things, no sulfhydryl, none of the kinds of things that would be reactive. And this is not ever going to dissolve. Ultra stable. Now, also, ultra biocompatible. They took a piece of silicone and a piece of sibs, not a tube, not draining anything, just put a piece of the material under the conjunctiva of a rabbit. And then you come back at 2 months and you see what kind of reaction did the tissue make to it. And the answer is, with silicone, as you know, if you've ever gone back on an operation of a AMED implant, for example, you got a big capsule. And in this case, there was new collagen, there were myofibroblasts, and there were blood vessels. And with the sibs, there's a tiny bit of collagen, but no scar tissue, no myofibroblasts, no new blood vessels. And if you look at the capsule under microscopy with silicone, not any aqueous going out there stimulating scarring, just the material touching the conjunctiva, a 200 micron capsule with blood vessels and fibroblasts, and here a 20 micron capsule. Now, aqueous still would stimulate scarring, so you need mitomycin to prevent it. They tried this without mitomycin, they had 60% success. With mitomycin, invented by C.C. Chen, or used by C.C. Chen to treat pterygia many years ago, and then used in glaucoma, it bifunctionally alkylates DNA. So the cells aren't dead. They can read their DNA and make collagen if they're stimulated, but they can't reproduce. So you don't get scar cells. Unlike 5-fluorouracil that just stops the metabolism for the period of time that the 5-FU is present. And is this Isabel Reese or you? This is probably Isabel. Taking a 25 gauge needle to make, now I would have put this closer to 12, but I think there's been a previous iridectomy. There's probably a previous failed filter to the side of it. So you make the needle track. Again, I would lift a little bit, and I would aim down and try to be just above the iris surface.
And we bend the needle.
And,
The wind is straight.
and put it in, and then very importantly, lift up the conjunctiva, make sure that the device is absolutely underneath and that it's flowing. Now they have a little cannula you can put over the top of to squirt fluid back into the eye to build up the pressure, or you could put some in through a paracentesis. You need to watch the flow to equilibrium, and I would add, which has not been done up till now, check the pressure, estimate the pressure by pushing on the cornea with a 30 cannula as I showed you earlier. You can learn to tell 0 to 2, 4 to 6, 8 to 12. And it's hard to tell pressures above that, but you can tell those ranges, and you do not want to leave the operating room with this having a pressure substantially above 6. And I understand Rachel had a case the other day. Where is Rachel, at any rate? Yeah, you had a case the other day where the pressure was higher and something had pinched the tube or gotten some pigment in it or something. So testing it like this before you leave the operating room, I think may be able to help to tell the cases, pull it out. It's either got some pigment or fibrin in it, or it's been pinched in some way. And that should solve this problem of just pull it out. It should be self-sealing, and put another one in. When Juan Baye calls up and says, hey, I'm getting pressures of 11, Rich Parrish says, Juan is a fine Christian guy. He's as honest as anybody I know. But he's operating on mixed race patients and getting a pressure of 11. Paul, why don't you go down and see the patients and measure their pressures? I said, okay. I mean, that's pretty impressive.
He brought a new camera,
So
3D.
yeah. So I came down and I calibrated. You know how to calibrate the Goldman applinator. And I took the pressure. In the first 5 patients, the pressure was 10. So that didn't make any sense. I mean, if they'd averaged 10, it would have been one thing. They all, by weird chance, if you could have bet on this, you could have made money. Anyway, the pressure was 10, and I recalibrated because it didn't make sense. You know, it was 10, 10, 10, 10, 10. Then the next one was 12. And I thought, okay, the machine works. And, you know, this is just so startling. Now, there's some things about the way he does it, making a lateral relaxing incision, lifting up the tissue, getting under tenas so that you're not getting bleeding there, and actually putting the device under and not into tenons that probably make a lot of difference. And he used a larger dose of mitomycin than some other people use who were not getting quite as good results. So we're in the FDA clinical trial now. We have 600 people. I'm a medical monitor. They don't let me see the data, but I do get called from time to time about things, and I haven't been called about much, so I guess it's going well. And you already know Juan's data, so I'm not going to show that to you. Juan, what did you want to say about?
Well, the key thing that needs to be known is that in the European study and also the US FDA study, they're using 0.2
for 2 minutes.
For 2 minutes.
Which is not enough.
That's not going to cut it. And then they say that, you know what they say is that, Juan, how come you get the lowest pressures?
The most mitomycin. And now ICOM has been using a bigger dose and also getting low pressure, so you're vindicated.
You know,
It's terrible to have something good. Like my patients where I had no net loss, I'd go to Arvo and show my poster, and I'd hear people behind me, the guy's an evangelical Christian. He thinks he can lay hands on people, you know. I mean, he's obviously deceived. There's no way you're getting an average pressure of 11, and there's no way that you're getting no net field loss over 5 to 10 years.
Ike was worse. He says, I don't know what they smoke down there. That's what he said.
Yeah. Well, but now he's done 400 of them, and he's become a believer.
Yeah.
Well, so at any rate, you took a picture where you were pretending it was like
St.
Jesus.
Thomas.
You know, St. Thomas, you know, he didn't believe it was really Jesus, and he's show me the hole in your side. Well, it was true. At any rate, this is the ADI, by the way, and this is where it was used and what the 93% success rate. I was just going to show you this briefly. Pressures came from 31 down to 13.5, and average 1 med. So the kind of complications were the ones that you will frequently see. They're about the same as what you would normally get with that device. So, bottom line on all this is now we're beginning to believe that even in mild early glaucoma, it would probably be better if you could have pressures down lower. It would be nice to sort out who those people are. And I want to show you one last thing that could change everything. Identifying who is the person who's at risk of getting worse. And I just, oh, here it is. So where's Cordiero? Here it is. Okay. So this, Dr. Maria Francesca Cordiero at the University of London, Moorfields Eye Hospital, has spent 25 years working on this. She wants to be able to see individual dying cells in the retina, and she's found a way to do it.
Okay.
And here's what she did. When cells are dying in the retina by apoptosis, which is how retinal ganglion cells die in the nerve fiber layer, they have receptors come to the surface to which annectin, a protein, would bind. Normally they're inside the cell, so it wouldn't bind, but they come to the surface so they could bind. And she made an annectin and modified the molecule to put a fluorescent probe attached to it. And it's a natural substance, and she has already tested this in human beings. You can inject it into the arm of the patient, and 45 minutes later, it's circulated through the body, and it's a natural substance, doesn't seem to cause any trouble. It's past phase 1, which means it's safe. It's in phase 2 trials now. And wherever you have a cell that's dying, this material will bind to it, and you can look at the retina 45 minutes later, take a picture with a fundus camera at the right wavelength, and in a normal aging person, you will see maybe one light up. And in somebody who has glaucoma, who's been progressing, you'll see 8 in the same area. 8 times as fast as normal loss of ganglion cells. Now, can you imagine that if a patient comes into your office, you could do this test sometime in the future? It's in phase 2 trials. They are apparently finished and about to publish, and then if that's good, it'll go to phase 3. Now, this depends on the loss being fairly steady, not episodic, because that would be harder to know what to do with the test on the day you happen to do it. But if it turns out to be something useful, in the future, the patient comes in, you find glaucoma, you diagnose it, you do this test, and you say, oh, this person is losing cells very slowly, maybe about twice as fast as normal. I'll just get their pressure down 20 or 30%. I'll give them a prostaglandin analog. Who's our sponsor? You might use you might use Travatan. Okay. Whatever. Zalatan, whatever. So then, if on the other hand you see they're losing cells 8 times as fast as normal, then you'd say, well, this is somebody where I really want to get the pressure down. I'm going to try to get it down I'm going to really throw some things at it, get it down at least 30, 40%. And then I'll do the test again. Now, my guess is these are also the people who may be the ones whose visual field recovers if you bring the pressure down, because the cells were dying rapidly. There are probably more cells in the process of dying that could come back. So it might be able to help us sort out who should get in-focus microshunt rather than medical therapy if medical therapy isn't just incredibly effective right away. Wouldn't it be great to individualize the therapy? I've shown you numbers. I've shown you statistics. I'd have to make 8 people better to benefit that one person who got better by 3 decibels. I wouldn't know who they were. You do this, maybe I would know, and I could target my therapy. And I wouldn't have to wait for somebody to lose another 3 decibels of visual field or another 10 microns of nerve fiber layer before I said, uh-oh, we drive down the street backwards in glaucoma. Oops, I better do something else. Wouldn't it be nice to go seeing where you're going and target the therapy to the people who most need it, and to know I stop cells from dying fast. They're down to the level that you lose with aging, and therefore I'm at an individual target pressure for this person. Well, we'll have to see if this pans out, but if it does, it changes everything. along with the ability to much more safely get pressures lower. Juan, what are you going to add to that? Outside of eat dinner or something?
No, we're gonna have dinner.
Okay.
Yeah.
Questions? Rebuttal?
Yeah, I wanted to ask a few questions.
Yeah.
All right. Now, we're gonna be doing 2 bar belts tomorrow.
Yes.
And theoretically, everything's gonna go perfect, but you know, yeah, it is. So, they're recording me. So, my question is, what can go wrong and how do you handle it?
We're doing oddies.
Right,
Okay.
right.
What can go wrong?
Yeah. And so we mentioned that you're going to do the needle track so that you have,
23 gauge needle track.
right.
Self-sealing. You don't lose the chamber, by
You
the
have
way.
the ligature, you're going to puncture the tube so
Yep.
you have an immediate result while the
Yes.
ligature falls out. But say the pressure is too low.
Not going to be too low.
Never.
If during the surgery you make...
No, I mean after in the post-op.
We are not having hypotony problems with the barbell.
Okay.
If
So-
you don't open it too soon.
Right.
It's very, very rare problem.
So, but you said you open it, but doesn't
one
it?
case of hypotony that happened in a patient out of 4,000 that I was involved in.
Okay. Now,
So that's pretty rare.
you said you don't open it. So do we have to open it, or are you allowing the
It
Vicryl?
will melt at 6 weeks and open on its own.
Okay.
I'm not sure that there are more than 1 or 2 cases out of 4,000 where we ever had to go back and cut it.
So she already mentioned we're not using the ripcord. Now, is it possible for the barbell or the Audi to erode through?
To erode through to the surface.
Yeah.
If we do it the way Felix Hill said, put it way behind where the upper lid rubs,
Right.
the risk is thought to be 1%.
Right. Now, your
In
tube,
5 years.
you said it looks ugly when you used patches, scleral patches, particularly a little better with corneal patches. Tell me about your little tunnel. What it is that you do?
I use the needle. I showed you.
No. Do you cover the tube with do you create a scleral flap or anything like
No.
that? Right over the sclera into the.
Yes.
Okay.
Now, if somebody had a lot of fat atrophy in their orbit or thyroid eye disease, you might want to enter the sclera even farther back. And if you did, you'd probably use Jamie Brand's idea that behind the 3 millimeter needle track, you would make like a belt loop in the sclera for another 3 millimeters, pass it up through those 3 millimeters, and then down through a needle track. So you have a belt loop up to a groove through which you're going in. That way, it's covered by sclera for 6 millimeters back of the limbus, and there's just about nobody where the lid rubs farther than 6 millimeters behind the limbus that I've ever seen.
So let me repeat something. Now you said ideally supratemporal.
Yeah.
Next best infratemporal, but never.
Never supranasal.
Okay.
I mean, you could put it infratemporal, but I don't get.
Now, if you
I like having 2.
if you have one of these hypotropias or restrictive strabismus, what do you do?
Well, the first thing to find out is what type it is. So when you get strabismus, if you get strabismus the next day and you have given your block into the inferior rectus and it has no action, that's from anesthetic. You just have to wait for it to recover. The next kind of thing that happens is you got a check ligament stuck and it's restricting the next day, but you'll see the eye, all the muscles will do something. They'll move, but they won't be able to move as enough you want. You've got to go back and get it free from the check ligament. If you have this problem develop 2 to 3, 4 months later during the hypertensive phase in the bleb, where it's a big high bleb, and like Ilda Capot calls me in and says, I don't know whether I as a, she said, as a pediatric ophthalmologist need to be there to do something with the muscles. And the pressure happened to be about 26. And I said, okay, we can answer the question. So we put in some aproclonidine, we put in proparacaine, we put in betadine. I took a 30 gauge needle and did a paracentesis. Pressure comes down to 12 when you do that. And the motility problem went away. Of course, it came right back. But we knew the problem
What's the
was
bleb?
a high bleb, nothing to do with restriction of the muscles. And in that case, you're probably going to put another tube in down below if you can't just get the vision together with prisms and wait it out. Or if that's not such a good eye compared to the other one, put a patch over that eye so they don't see double until they resolve the hypertensive phase. If not, then you're going to do another tube down below, and at the time you do that's working, you could go back and close the other one off. Or the pressure might be low enough from the second device that you didn't have to, it resolved.
So every so often in the Ahmed valve experience, and I'd say 5% of the cases, maybe even higher, we get tenon cysts
Yes.
around it.
Yep.
So we unroof it and it works back again. What do you do with the bar valve? You get them?
You can, and you can needle them if the conjunctiva is freely mobile over another layer underneath. You can bend the needle so that you come under the conjunctiva from about 10 millimeters away up to the dome, puncture it, and you'll see a spreading hydration of tenons. And that was successful in 6 out of 9 cases. But if it's vascular and not mobile, I just go and put another device in down below.
Okay.
And not revise, because revisions haven't worked as well as doing an operation in fresh tissue, and they have led to problems with melting conjunctiva. You've now interfered with the blood supply enough that you might get an exposed plate. So I think it's better just leave that alone. You're getting something out of it, maybe, and put another one in. And frequently, at that time that you have a lower pressure, this one will come down, get softer.
Keeping on the fast track, the cornea folks hate us for putting tubes in their eyes because they say the main indication for DSEC and DMEC is the tubes from...
So again, I would stress that tubes either should be in the posterior chamber, the vitreous cavity, or the needle should enter through the trabecular meshwork or scleral spur, not through peripheral cornea, for one thing. I do think that if you have the tube obliquely, if you should push on the limbus the way a blink would do, the tube doesn't have that tendency to come up as it does if you're straight in. It has more of a tendency to go down. When the pressure is on a tube sideways, it's different than when it's on a tube straight. And I like to have it down near the iris surface to be as far away as possible. But there apparently is something about a tube in the eye that is allowing stuff into the eye from the outside, or oxygen, or who knows, that is causing corneal problems with the big tubes. Now, in the in-focus microshunt trial in the FDA, our DSMB, our monitoring committee, is looking at trabeculectomies and the in-focus microshunt because of what happened with the CyPass. And they are looking at it, and I don't know, I don't get any unmasked data, so I'm not telling you anything. Except that they have not been concerned out to 2 years, out to 1 and 2 years. And they've taken corneal thickness measurements at baseline 3 months, 6 months, 12 months, 18 months, 24 months. And I have a feeling the FDA is going to want us to do it to 5 years. Yeah, and they should. So, but I think that the idea of stuff coming in and out of the eye is what you see with barbells. You know, somebody blink, you can see fluid moving in and out. If there's ever any fibrin near the mouth of a barbell, you can see it. It's like a little heart moving back and forth with every pulsation of the vasculature inside the eye. The fluid is moving a little bit, and you can have a lot of diffusion from the inside to the outside of cytokines or other things. So we don't know why the corneas are not liking big tubes as much. So far as I know, they are not having the same problem with small tubes.
So we got retina boys, cornea boys, cataract boys, and girls, and the question is timing. So if I'm going to do a pars-plana vitrectomy and a Barvelt or an ADI, tell us how you sequence it. I mean, can you do it at the same time?
Oh, yes. Well, if the pressure is 55, but the nerve is not badly damaged, I put in an Ahmed, do the vitrectomy, stick the tube in the pars plana. If they need a vitrectomy, if they don't, I would stick it in the anterior chamber, but I'd put some Helon in, and I would pull the iris off the angle in 1 clock hour, so the tube would come through trabecular meshwork, not through peripheral cornea. Or if they're pseudophakic, I would put it in the posterior chamber with the bevel down. But I would definitely do them at the same time. We do it all the time.
Do you do any adjustment for those that are going through the pars-plana? You know, they talk about these elbows. And
don't ever use the elbow. It gets exposed. It's not necessary. All you have to do, the tube will bend, but don't bend it 90 degrees. Just have it parallel to the sclera until you go in, and then be parallel to the iris.
Okay.
and then it does not get kinked.
In K-Pros, how do you handle them? Do you do the tube first and then the K-Pro later?
No, we haven't put the K-Pro in and then we stick it in.
At the same time?
Yeah, oh yeah.
Okay.
Oh, and every K-Pro needs something because,
Yeah, there's no
70%
angle.
of them are going to get glaucoma. So, and very bad glaucoma. And the only thing you can follow, well, maybe if you can get your fingers out peripherally, you can do finger touch pressure. But other than that, you're watching the nerve. And K-Pro 2 is really interesting. Because it's sewn, the eye is sewn around the device, so there's no chance to measure the pressure. Be nice to have a pressure gauge in those eyes, I suppose.
Do you close tightly the tube before to put inside the?
Well, the bar belt, absolutely.
Okay, and
Otherwise, you would have severe hypotony.
You are going to have high pressures after the surgery.
Well,
You keep the drops, the high.
so first of all, we fenestrate the tube with the needle of a 7/0 Vicryl 2 or 3 times. And then you wait for the pressure to come to an equilibrium. Pushing on the cornea with that cannula, I can estimate, and I want the pressure to be about 12. If it still feels like 20, one more fenestration. If it now feels like it's 15, one more fenestration. If it feels like 10 or 12, I'm happy. If it feels like 6, I'm going to tie it off with another ligature and try some fenestrations in front of it. Now, you don't worry about the fenestrations. I mean, there's tissue that's going to heal around where those holes in the tube are. That won't last it doesn't last as long as you want. Some people have put a 10-0 Proline through the fenestration. Jamie Brandt has, and he's kind of happy with that. I haven't quite gotten to doing that yet. The patients who have really high pressures, I put in an Ahmed. I want it down now, and I find it's very difficult in the first 3 weeks to control the pressure with a bar belt. If somebody has very thick tenons, then instead of using a Vicryl behind, I would use a Proline around near the tip of the tube. Now in that case, of course, you could fenestrate the tube where it's going to be in the anterior chamber, and a little will get out that way. It's a little harder to adjust things. But because I know I can always see it to heat it, to get it open. And don't break it, just heat it enough that the cheese melts and recoagulates and stays around the tube. You don't want that thing, the stitch floating around the anterior chamber, or you'll see some snail tracks and you'll have to get a Sinskey hook and pull it out of the eye, the loose stitch. Well, that's basically everything I know that's relevant to these 2 topics. Yes?
How's the follow-up of those patients? How frequent?
One day, the pressure's really good. Another week. If it's really good, probably another 2 weeks and a month. And then monthly until you got what you want. You get them through a hypertensive phase. After that, probably about every 3 or 4 months. Not too different from a trab. Except that there's only one suture you can cut and it does everything.
So,
Yes, sir.
Papa, thank you so much.
Oh.
You get a big hug. Now, this is a historical moment for us, and it is not very often that Dr. Paul Palmberg comes to visit the Dominican Republic.
Only about 20 times.
But tomorrow is when the action begins, and we are going to begin at 7:30. My head nurse is going to be there at 7 o'clock. We have 2 tables. Each table has 4 cases, a bar belt, and 3 in-focus microshuts.
All right.
So we need the
video
faculty.
at the time, people?
We all have video capability. There will be faculty. William McCollum is going to be running the organization of the operating theater. We got the big room, so we got plenty of space for people that want to observe. Just do not get in the way. No talking. I don't want cell phones in there, and I don't want videotaping in there because we're doing our own. So just get in there and watch, participate, and do what you have to do. And whoever is in rank that's going to be helping us, well, they take their turn. Don't fight over it either. Okay?
All right, good.
Dr. Palmberg has to be heading out of the hospital 12:30 sharp, hopefully with some food in his tummy. So we need to get going so that by 12 o'clock we're all done.
Should be.
Okay?
Yeah, I mean, InFocus takes what, 15, 20 minutes?
We try to get as many that were just the IMS, meaning no combined. I think there's one or two that are combined.
Great.
And I'll do the faker.
You're the man.
All right.
So
So-
I see patients who need a very low pressure, and they have, money and ability to travel, and they say, what's the best thing I could have for my glaucoma for a first operation? I say, well, you can go to the Dominican Republic and lie on the beach and have Juan Bailly do it, or you can go freeze in Toronto and have ICOMA do it. And those are the two places in the world I would go to get my eye done.
There you go. Okay.
Because I can't do them in Miami yet.
Okay. So, buen pro. Alcon, we want to thank you. Big hand for Alcon for their support, for their generosity. You're very special to us. They sponsored our meeting this year called Cohesive. It's the Congress of the Hospital Elias Santana, so it translates to Cohesive.
All right.
So we had 150 players from all these years come together, and that was really wonderful. There you go. Bueno, muchas gracias. Buen provecho. Buenas noches. So I do know that Dr. Gomez is here. He's the first and the one and only. So come up here and bless.
I have to tell a story on him.
Okay. Come up here, guy.
Okay, so he came. The first time I came to your clinic, I was going to show people how to do a trabeculectomy. So I did one. It took me about 45 minutes. And I said, "You got that?" He did his in 15. And I turned to him and I said, "See what a good teacher I am."
So Carlos, can you bless dinner for us? All right.
Well, Heavenly Father, we thank you for the opportunity you've given us to share with Paul Palmberg here about all the knowledge he has to share with us so we can do better for our patients. We thank you for the chance you give us to gather together and do this at least once in our lives. We thank you for the food we're about to take and bless it to our bodies. In Jesus' name, amen.